Good evening and welcome. Thank you for joining us for today's presentation on lung cancer screening and treatment options. My name is Michelle Zepeda, and I'm the program coordinator at Waterford Place Cancer Resource Center. Waterford Place provides programs and services free of charge for anyone impacted by a cancer diagnosis that supports whole person care. I am pleased to introduce our two speakers this evening, Dr. Justin Karush, thoracic surgeon, and Dr. Phillip Bonomi, medical oncologist from Rush University Medical Center. Both will give their presentations, and we will allow the last 10 to 15 minutes for Q&A. Our first presenter will be Dr. Karush, who will discuss cancer screening options, followed by Dr. Bonomi with treatment options. So thank you both for being here, and Dr. Karush, I pass it along to you.
All right. Again, thank you for the introduction. My name is Justin Karush. I'm a thoracic surgeon at Rush, and I also work at Rush Copley. You know, as a surgeon involved in lung cancer, I have many different roles, but the role I most prefer is when I have the opportunity to remove stage lung cancer. You know, the opportunity to offer a patient a cure with a surgery, with the potential of not requiring chemotherapy, is kind of as good as it gets for me. The problem that we have is that those types of cancers, those early stage lung cancers that offer the best chance of survival, are asymptomatic. And so, you know, patients will never know that they have them. And if we wait for patients to come to us, what we find is that we're diagnosing advanced stage disease. And so, you know, it's our job to look for these cancers. And we can do that in a couple of ways that I'm going to talk about what we're doing at Rush and what we've been doing and some of the things that we're excited about in the future to do a better job for our patients. So I'm going to talk a little bit about the evidence that we have to support lung cancer screening. So this is a classic slide that basically just says that lung cancer is a leading cause of cancer deaths, and it takes more lives annually than the next 4 highest cancer killers combined. That's colon, breast, pancreas, and prostate. And there are several reasons for that, but one of the principal reasons for that is those other cancers have population-based screening programs. And not until fairly recently, and it's still in its infancy, unfortunately, you know, lung cancer has not benefited from lung cancer screening. So as I mentioned, when we don't look for it, when we wait for patients to come to us, this is what we find. We find that 57% of patients present at stage 4 disease. There's no chance for cure for those patients, although I'm sure Dr. Bonomi will talk about some of the breakthroughs we've had in the medical management of these patients. You know, that's not our goal. Only 15% of patients who present to us, and most of these are incidentally found. We're going to talk about how we're sort of harnessing those patients as well, but only 15% of these patients have localized disease, which gives me and my colleagues, surgical colleagues, really a chance to go to work and do some good. When we look at survival, you can clearly see how important it is to diagnose lung cancer early. When we can find lung cancers that are stage 1, we can offer patients 77 to 92% 5-year survival, but it drops off pretty significantly after that. So there's a tremendous motivation for all of us to find patients with early stage disease. When we do that, now I'll back up just a little bit, in too much detail, but it was 2011 randomized trial came out that showed that low-dose CT scan improved survival. And that was the genesis of lung cancer screening. And it wasn't until 2015 that there was CMS approval for it. So we're working in, you know, a 5-year period now. When we look at our data, this is Rush, these are our patients. This is the stage at diagnosis. So it's a complete reversal. We're seeing essentially 45% of patients are stage 1 and only 6% are stage 4. And the truth is there's nothing special about these numbers compared to anybody else's screening numbers that have been published. This is simply what you find when you go looking for a high-risk population of people. Until recently, well, currently, and hopefully this will change, I'll talk more about it, the criteria for lung cancer screening has been, it's not been fantastic in the sense that it's a very, very, very high-risk patient in a very specific age range. We're talking 55 to basically 74 and 30-pack year smoking history. So there's many patients who don't fall into that category who we know are still at high risk for lung cancer. We know this net is not cast perfectly, but until very recently, that's the data that we have. But it's still, it works. It's incredibly important for us to do, and you can see that in this slide very well. Again, our own patients, this is from our data. We screened 600 patients in the first 3 years since CMS approval. And in 604 other cancers. And so that amounts to 28 patients screened for every diagnosis of lung cancer, which is incredible. And when you take all cancers included, 1 in 20 patients. So, you know, smoking imparts significant risk. There's even a survival benefit to screening patients with CT scans that has nothing to do with lung cancer. There's a 6% survival benefit, all cause. We're diagnosing patients with coronary artery disease. We find lots of things that are very treatable, and we're doing good things for patients when we do that. Despite how awesome that is, which it is, 2016, less than 2% of the eligible population was actually getting screened. That compares to about 50% of patients who are eligible for breast cancer, 35% eligible for prostate, and 63% eligible for colorectal cancer. So that is the sobering part here. Now we're up to about 4%, I believe, from last year, and this is gaining steam. Nothing happens quickly. It would be the focus of an entire talk explaining some of the pitfalls that we have to get lung cancer screening widely adopted. But education is one of the big ones. Educating patients, educating practitioners, making it easier for practitioners to go through the process that's required of them. And those are some of the things that we're doing, and we're results. Pre-COVID, our screening had gone up dramatically, and we were extremely proud of that. So one of the other things that we've employed at Rush, we're beginning to employ at Rush, that we're incredible software. Actually, 2 things here. There's a lung GPS called Dynacat. And there are 2 things. One is it's a software which we've never had before that is dedicated to lung cancer screening. Now, at a place like Rush, we have world-class radiologists who can read these screens backwards and forwards. Not every hospital system has that expertise. And so this software is a package for radiologists to track these nodules, the sizes, the densities of these things, so the care team can implement the right plan. And it also helps us track those patients. We have dedicated nurse coordinators for our lung cancer program, our screening program, and they have worked very tirelessly with Excel spreadsheets and now have modern software in order to help track patients throughout this entire process, so it's just a more seamless experience. The second thing this does is something called incidental lung nodules. So as I mentioned, that 15% of patients that are found with stage 1 disease, again, those were asymptomatic patients. Those were lung nodules that were simply found incidentally. You get in a car accident, you get a CAT scan in the ER, you find a lung nodule. Sad that it is, that's what it takes to find their lung cancer, and it was the luckiest car accident they ever had. That's not what we're going for. But as it turns out, unfortunately, many of these lung nodules that are found are, they're read in a radiology report, and then it goes to an ER doctor, a primary care doctor, and many of those can be essentially lost. They're not followed. And so what this software does is it uses artificial intelligence to read all of the radiology reports within our system It uses language recognition to figure out when a lung nodule or a ground glass opacity, all the different things that we're interested in, is identified, and then it shunts that report to our team. Review it, to either agree with the recommendations, potentially to add our own recommendations. It allows us to draft letters and contact primary care doctors to make sure they are aware of the incidental finding and to make sure that it is tracked. And then over time, it reminds us this patient needs a CT scan in a year, and we're drafting more letters to practitioners to make sure that this happens seamlessly. So we're very excited to get this up and running at all 3 of our major sites. And we think this is going to go a long way to make sure that patients get a smooth experience and we're not missing anything for anybody. The other exciting thing that happened recently, pretty recently, this was February of last year, is there was a new randomized control trial in lung cancer screening. I believe this was out of Holland. What's exciting about this is it established the survival benefit that we knew. It was actually a little bit better, in fact, in this trial, but comparable. But what it did, a lot of, I know, patients have been waiting for, certainly we have, is it expanded the eligibility criteria. So these were younger patients. They were as young as 50 years old, and they had less smoking history. So currently you need to have smoked a pack a day for 30 years or 30 pack years smoking history. And this was about 20. So we're talking about patients who, again, younger, less smoking history, would not have been screened previously, but have clearly been shown to be at risk for lung cancer and to have a significant benefit from being screened. Now we have a trial that says we should be doing it. And so these recommendations have been made to change the age range from 50 to 80 years and to change the smoking pack years. And we are expecting this to change, and we are hoping to have an answer within the next year. I'm going to talk briefly about COVID, as that has changed a lot of things for a lot of people and a lot of doctors, and clearly patients with lung cancer are at-risk patients for COVID. It introduces a lot of difficulties in terms of what we should do and what we can do for patients during this period of time. So the reality is there's no ideal single approach. There are expert guidelines that we reference that we can use to help us make the best decisions for patients. But no matter what we want to do or what we think we should do, we have to be clear that decisions will depend upon the local state of COVID in your area, how many healthcare workers you have, how many beds you have in your hospital. Those are certainly realities to how we're practicing medicine these days. One of the things that we can certainly do to decrease the risk for patients, we screen patients for symptoms, go into the hospital for every patient, expand hours for patients to come in and get their screens. We have more time in between screens, so patients are not sitting in waiting rooms next to each other. So there's things we can do to lower that risk and things that we are doing. The other thing that has come out of COVID, but for all of medicine, is we're sort of entering this era of telehealth. And we need to maximize what we're doing electronically, be it video visits, telephone visits. We need to keep in touch with patients remotely when they're safe, they're in their homes. It's something we've been doing since the spring, and I can tell you personally, I feel like this has been a wonderful thing. I think that patients are not missing out too much from the experiences they've had at home with their physicians. I think my colleagues would agree with that. So I think this is something we'll be doing in the future, even once COVID has resolved. The other thing with telehealth is that CMS approved shared decision-making. Without going into too much detail, Shared decision-making is a process that has to take place prior to ordering a lung cancer screening, where a patient and a physician have a specific discussion, benefits and risks, and the patient has to be well informed as to what they're essentially getting themselves into. There's no other screening modality that requires this. It's one of these cumbersome things that makes it difficult for primary care physicians to offer screening to their patients. But CMS did approve us to at least do this remotely, which is making lung cancer screening via telehealth possible. There are guidelines for patients. I'm sure there are some of you who are out there listening who may be in surveillance, and we do have guidelines for you. You know, the goal is to delay if we can and if we have to. There are a list of priorities for which patients can be delayed, and we're talking usually in the range of 3 months, maybe 6 months, depending again on the state of the world and the state of the patient. What is the suspicion of their lesion? And again, there are guidelines to help us help you. The reality is there's risk and benefit to anything that we do. And so that's something that we're weighing constantly when we're making decisions to bring patients in, whether it's just to get a CT scan, come into the office, go to an operating room and have a surgery, or just sit tight. So it's a case-by-case basis. Communication is extremely important. We want you to communicate with us. If there's any questions and you're feeling like you're in the dark, by all means, reach out. And I think that through great communication, we're going to be able to stay on top of what we need to and make sure that people are being safe, but also being monitored. So just to kind of summarize, you know, we talk about changing. You know, we're getting away from the era of waiting for patients to come to us, diagnosing stage 4 disease, and having the sort of mortality numbers that we started out looking at. So what we're doing at Rush is we're trying to increase the utility of our lung cancer screening. We're trying to improve the education. We have primary care physicians who are as passionate about this as we are, and they are some of our greatest assets in helping to educate their own colleagues in that arena. And we're basically constantly educating our primary care community and our patients, as you know, I am right now, so that you're informed and you can go in and ask questions, which is something that obviously we want you and need you to do. We're very excited at the possibility of expanded eligibility requirements. Again, if we can drop the age and the smoking history, there are a lot more patients who can be screened. Now, we're still a ways away from getting them screened. Like I said, we're up to about 4% of the current eligible population, but we're gaining steam and we're going to continue to do so. I'm very confident in that. I think over the next 5 to 10 years, we're going to see those numbers go up dramatically. We're going to find a lot more patients that we can do a lot of good for. The other thing that we're doing is we're looking at smoking cessation. So, you know, we have a population of people who just to get into the door for a screen are obviously significant smokers. And so it's an opportunity not just to screen for cancer, but also to assist in their needs for smoking cessation, which is obviously a tremendous benefit to that patient population. We are about to open, we've been working tirelessly for a few months now to open a randomized controlled trial with Memorial Sloan Kettering that is actually looking at specific methods of smoking cessation in this population to see what the optimal method is. And I think that's going to provide a great patients as well. We have dedicated software to systematically identify and track both incidental lung nodules as well as the screen identified nodules. So this is us sort of taking control of everything that we possibly can. Any nodule that comes into our system that's incidentally found, we want to own it. We want to know what it is. We're gonna say dictate, but we're gonna at least have our say in how this should be followed and have the capacity to follow it well. And we are going to screen as many patients as we possibly can, and we're going to track those patients and do the best care for them that we possibly can. We're improving patient access across the board through telehealth. Like I said, we're doing this during COVID. It's picking up steam, unfortunately, as the winter comes, and we're going to be moving even further into this over the next 3 to 4 months. I'm certain of that, but I'm also certain that we're going to be it's going to be good for patients. It's going to improve geographically are not close to us. People who physically have a difficult time getting into the hospital, we're still going to be able to take care of those patients too. We're very excited about doing that. And that's all I have.
Okay, so Dr. Karush has summarized very nicely the screening effort, which I believe is going to have a huge impact on the mortality rate in lung cancer. He also has shown, I'm skimming through some of these things. I'm going to skip this because he pointed out already that there are many patients who come in with lung cancer. It's already very far advanced. And the majority of them, of course, are they're smokers or former smokers. Well, you see in this slide, 87% have smoked, but the thing that's distressing to me, and it's sad, people stop smoking, and doggone it, if lung cancer doesn't still catch up with them many years later. I don't want to send the wrong message, because certainly stopping smoking reduces your chance of getting lung cancer, but it doesn't totally eliminate it. The other interesting thing, and again, unfortunate thing, is that 30,000 people a year roughly get lung cancer, and they never smoked. It's more cases than stomach, ovary, adult leukemia, and Hodgkin's disease combined. So it's not so uncommon. We don't know why that happens. The majority of the lung cancers are non-small cell type. That's a diagnosis made when the pathologist looks at the biopsy specimen under the microscope. And in the non-small cell, the majority are actually, over here in the purple, they're mostly adenocarcinoma and some others we call not otherwise specified. So this is, the adenocarcinomas has been actually one of the success stories in the treatment of lung cancer. This is, I've been working as a lung cancer medical oncologist for close to 45 years. And the things that we've seen are, we had platinum-based chemotherapy. And in the 80s, the big improvement was platinum was minimally better than supportive care alone. Showed that chemo actually had some effect in improving the survival of the patients. Then in the 90s, we had a group of new chemotherapy drugs. We were very, very excited, but they weren't that exciting. There was just a little improvement by adding those drugs to platinum. But in the 2000s, we really launched into something that has changed the whole treatment of advanced lung cancer, non-small cell lung cancer, and that was the identification of targeted therapies that we'll talk about in more detail in a few minutes. And then in the 2010s, actually 2015 was the first immunotherapy that was approved for treating lung cancer. And these are therapies that release the brakes on the immune system so that they can attack the cancer. And what our hope is now in stage 4 disease, we can convert many of these patients' histories to one where they have a chronic disease they can live with. And many of us believe that immunotherapy is going to cure some of these patients. Now, back in 2011, these two brilliant scientists put together a lot of information about cancer. Excuse me. And what they found is that cancers have certain characteristics which they called hallmarks. And the two that actually in lung cancer have been capitalized on the most are cancer cells are growing when they shouldn't be growing. They should be sitting there quiescent, but they're forming new cells. When I started out, people thought, well, cancer grows faster than normal cells. It really doesn't grow faster most of the time. But what happens is the cells are increasing from 2 to 4 to 8 to 16 when they should be maybe increasing from 1 to 2 or none. And the other thing that they have is normal cells, like cells that line our intestinal system, our skin, they form new cells, and then they're programmed to die when they become old. And old for cells lining the intestinal system and the skin is probably 3 or 4 days. So they would get programmed to die. So the cancer cells first have one thing going on, which is they're proliferating when they shouldn't be, making more cells. and the individual cells that are made are living longer. So those are two things that give them an advantage. Now, here is the target that was the first one identified in lung cancer. It's called the EGFR protein. And this is a cell membrane here, this orange thing. And outside is a part of the protein that can bind to other proteins called a ligand binding site. And then within the cell, there is an enzyme that turns on cells so that they grow, so that they invade, so that they make new blood vessels to help feed themselves, so that they can metastasize, and then they avoid death. We call this inhibition of apoptosis. So these are the things that the scientists had identified. And many people noticed that EGFR was a normal growth pattern in many cells, and it was increased. The expression of that protein was increased in non-small cell lung cancer. And it might be an important target in non-small cell lung cancer. When we started testing these EGFR inhibitors, 10% of the patients had responses like we had never seen before. In fact, at Rush, we were lucky. We and 3 other institutions were the first group in the nation to test the drug called Tarceva, which was the first EGFR inhibitor that was approved for the treatment of lung cancer. So before I talk a little bit more about that specific gene or EGFR gene and protein, I want to just talk about mutations. So genes direct the biochemical pathways in our cells, and they make the cells become heart cells and perform like heart cells, lung cells perform like lung cells. Well, they can be mutated. They can go haywire. There can be a biochemical change in them that makes them behave badly. Lung cancer has a really high rate of mutations. Most of these are what we call passenger mutations. They're there, but they don't do anything that we know of. They're kind of along for the ride. But there's some mutations that are driver mutations. These can be very, very important for cancer cells. And essentially, the cells that have driver mutations, they become addicted to those biochemical pathways for them to proliferate and to survive longer than they should survive. And if you could shut them off, you could really make a big difference. Now, when we did the first study with the EGFR inhibitors, we saw these amazing mutations. We and other investigators did, and we talked to the folks who were making these medicines, the targeted therapies. We said, we've got to be able to figure out how this works. I mean, we know the pathway, and they said, it's really complicated. It's really going to take a long time before this is figured out. Well, this is a success story that shows you where there's a will, there's a way. And if you have an open mind, you might be able to see something that's really important and then capitalize on it. What I'm leading up to is these EGFR inhibitors were being used now in more places, in more studies, and people were seeing these great responses. And so there was a young woman who was treated with an EGFR inhibitor. She was a never smoker. She was in her 40s. She was a nurse, had 3 children. And she got treated with one of these pills, and they're all pills. And she had a great response. And several years later, the Boston Globe had a story about her in the Sunday edition, talking about how well she did, how this new therapy worked so well for her. And the lung cancer doctor, Dr. Tom Lynch, who was taking care of her, got a call that morning from his boss, who was a breast cancer doctor. He wasn't involved in lung cancer research. He was a breast cancer doctor. And he called Tom and he said, "How many patients do you have like this that have these dramatic responses?" And Tom said, 10 or 12. He said, "Do we have the biopsy specimens here?" He said, "Yes." "Well, let's get those biopsy specimens because I want to sequence the EGFR gene because I think they have a mutation that is driving their growth and the survival of the cells. And Tarceva, that medication, is working on those cells that have that mutation." And that's exactly what they found. And that led to, from there, an explosion of research in molecular biology and lung cancer and many, many advances. Now, here we knew now that these EGFR inhibitors could cause dramatic responses, but here was a real practice-changing study. This is a study in patients whose tumors had EGFR mutations. And previously, we had just treated them with chemotherapy. So these investigators designed a study where half of the people got treated with chemo and half of the people got treated with an EGFR inhibitor. So this is the EGFR mutation slide or survival graph, and here's the EGFR mutation negative. So here's positive EGFR mutation, negative EGFR mutation. The green line is the EGFR inhibitor, and the orange line is chemo. So the EGFR inhibitor is way better than chemo if you have a mutation. And if the other way around, you didn't have a mutation, actually chemo is better. This led to a real practice-changing paradigm. So that point at that time, EGFR inhibitors became the standard first-line therapy for patients whose tumors had EGFR mutations. Subsequently, second and third generation EGFR inhibitors have been developed. This one is, the generic name is osimertinib, but you would know it as by the name Tagrisso. And in this study, patients with EGFR mutations were treated initially with Tagrisso or with either Tarceva or Arisa, which were the first generation EGFR inhibitors. And again, you see the top curve here, superior control of the cancer, and now we know even superior survival occurred in the patients who got treated with Tagrisso, and it became the standard of care. So I'm going to skip this because we have many other things to talk about, but just talk about right now the standard of care for first-line patients who have EGFR mutations in their tumor is Tagrisso. That led to a total change in the way we did things. Well, another mutation that was found is called ALK rearrangement. And this was discovered at first actually in malignant heme tumors. But then at some point, people say, hey, we also see this in lung cancer. This is a chromosome over here, another chromosome. There's orange and yellow. I know it's kind of small. These things got flipped around. It's called an inversion. And so this is what happens when the ALK gets rearranged. That thing gets flipped around, and then it drives the growth of the tumor and the survival of the individual cells. This is a study, again, showing the first ALK inhibitor, crizotinib, also called Xalkori, compared to chemotherapy alone as first-line treatment in patients whose tumors had ALK rearrangements. Again, a dramatic improvement in favor of ALK inhibitor. Now we've developed, or scientists have developed newer ALK inhibitors, second generation. There's even some third generations on the way. But here's a study looking at a second generation ALK inhibitor versus the first being crizotinib or Xalkori, the drug we just talked about. The newer one is called alectinib or Alecensa. And here you see alectinib is dramatically better than crizotinib. And so another paradigm shift in treatment, and that became the standard therapy for people with ALK rearrangements. Now, in addition to just working better in general, it also worked extremely well on brain metastases. So in this slide, what we see is over a couple-year period, this is the frequency of brain metastases in patients whose tumors have an ALK rearrangement. It's about 50% when you get out to the 2-year mark. If you treat with alectinib versus a pure crizotinib, which in fact has some activity in brain metastases, but Alecensa is way, way better. So you see here, probably it's a little over 10% are getting brain metastases versus almost 50%. If you didn't have an ALK inhibitor at all, that number would even be higher than this red line. So again, another amazing discovery. So the bottom line here, alectinib is highly effective in brain metastases. It has become the standard treatment for patients with ALK rearrangements. It is chosen over chemo, is chosen over the earlier ALK inhibitors. Now, there are many, many other mutations, and I should point out these all occur primarily in adenocarcinoma of the lung. The other types of lung cancer, squamous and small cell, really don't have these mutations, but adenocarcinoma has many of them. And the most common one, called KRAS, so far has not been very much success with it. EGFR and ALK have been the two biggest success stories because they're the most common after KRAS, and we have very good treatments for them now. But here's a whole list of new targeted therapies in adenocarcinoma of the lung, which have been approved by the FDA within the last 5 or 6 years. One of the other rearrangements called ROS1 has 3 different drugs that work. All of these drugs are pills with relatively minor side effects. They have some side effects, but when they occur, they can be managed by adjusting the dose of the treatment of the specific drug. BRAF is another mutation. This one is harder to treat, and it requires 2 targeted therapies combined to work. RET is another fusion. This agent here, selpercatinib, has recently been approved. There are a different type of EGFR mutation called EGFR exon 20 insertions. These have been hard to treat compared to the ones that I described earlier, which occur in different areas of the gene. There are drugs being tested. I believe some of them will reach approval, but we're not there yet. MET, another mutation, and so here's a couple new MET inhibitors. NTRK, another mutation, 2 new inhibitors of that. And then down in the bottom here, HER2, which is prominent in breast cancer, has some role in lung cancer too, and there are drugs being tested to try to treat HER2. KRAS is the most common mutation. There is a compound now that looks promising in clinical trials. We're hoping within the next year or 2 that this will also be approved because it's been shown to be safe and effective. The FDA, I want to tip my hat to the FDA because they have a hard job. They don't necessarily have a large group of people, but they have approved many, many drugs for lung cancer over the last 10 years and in other cancers too. So they've done a wonderful job. The other message here is a patient with lung cancer, especially adenocarcinoma, their tumor should be sent for genomic analysis. And it can be done with either a piece of the tumor, or it also can be done with blood tests. Because the DNA that is in the substance of the nucleus leaks out of some of the cancer cells, and you can detect it in the blood. So patients, especially never smokers with adenocarcinoma, should definitely have mutation analysis of the tumor tissue, mutation analysis of the circulating DNA, because it gives an opportunity to be treated with one of these therapies which prolongs their lives and generally has minimal side effects. So all patients with adenocarcinoma need to have genomic profiling when their treatment is being planned. Well, we talked about the Hallmarks of Cancer before. That was published in 2011. And then a little more recently, they talked about emerging hallmarks of cancer. And one of the big ones was avoiding immune destruction. Tumor cells should be cleared by the immune cells. Immune cells should attack the cancer cells and kill them, and that's it. They never develop. But they have developed ways to evade the immune system. Back when I was in medical school in the 60s, immunotherapy, or not immunotherapy, but immunology and immunobiology were starting to be studied, and we're starting to learn some new things. And many of us thought, wow, this is really going to be the answer for cancer. It's going to be here soon. Well, it is turning out to be the answer for a lot of cancers, but it didn't happen very quickly. And again, my hat's off to the people who are immunobiologists and clinicians who were working with immunotherapy. They believed that this was a good idea. They were correct, but study after study of different types of immunotherapy didn't work. And it was very disheartening, and people became depressed, in some cases, fairly cynical. Oh, another immunotherapy trial. Oh, come on. I don't even want to do it. It doesn't work. Doesn't help my patients. Well, as I mentioned, the immunobiologists, scientists kept working on this, and they looked at the immune cycle. What they found, here's a tumor, and what happens is tumor cells have proteins on the surface which are a little different than the normal proteins because of the mutations. Mutations in the nucleus forms these proteins that are a little different. And then they get secreted into the, some of them are shed from the tumor surface, they get into the bloodstream. They're picked up by antigen-presenting cells because these proteins are called antigens. They could stimulate an immune response. they're picked up by these antigen-presenting cells, and then they're processed. Then these antigen-presenting cells interact with the lymphocytes that have the ability to kill the cancer cells, but they can't do it unless they get activated. These antigens are presented to them and they get activated. Then they can go to the tumor. And when they get to the tumor, there's a protein on the surface of the lymphocyte called PD-1 and a surface on many tumor cells called PD-L1. If those two proteins lock horns, it essentially shuts down the immune cell so that it can't kill the cancer cell. That's one of the ways that the cancer cells evade being killed by the immune system. Well, they kept studying these things. They came up with, well, we call them immune checkpoints. I think a good way to think about it is kind of like a rheostat. You can turn the lights brighter or you can dim them. And there's a balance. So the immune cells, they have to be able to attack foreign things, viruses, bacteria, cancer cells, but they have to be shut down so they don't attack our normal tissue. If they attack the normal tissue, we get diseases like rheumatoid arthritis, lupus erythematosus. So there has to be a balance. Well, the cancer cells turn that balance towards brighter so that they are dimmer. They shut it down so that the lymphocytes can't attack the cancer cells and kill them. So they take normal mechanisms and they use them to their advantage. Well, what did the scientists say? Well, we got to figure out how to turn that balance around so it's more favorable for the patient, for the immune system to kill those cancer cells. And we use a simple term that we try to release the brakes on the immune system so those immune cells attack the cancer cells and kill them. Now, here's the first study that was done by a very good oncologist at Johns Hopkins named Julie Bramer. It's interesting for me. I've been doing this for so many years. I remember when she was a fellow at Hopkins and young attending at Hopkins. Now she's become one of the leaders in the country in terms of immunotherapy for lung cancer. In this study here, we see a graph where here's immunotherapy up here, here's chemo down here, and people surviving longer because they got treated with immuno. These patients were sick patients. They had been treated with some chemo already and their cancer was progressing, and they would be treated with this chemo drug, which helped a little bit, but not very much. Immunotherapy compared to that was way better, and this led to now like just a tidal wave of new immunotherapy discoveries, new immunotherapy treatments. In the early studies with the immunotherapy, one of the drugs here, Nivolumab, you see it advertised on TV under the name of Opdivo, they treated several hundred patients in the phase 1 study. Now, that's very unusual. Chemotherapy phase 1 studies, you treat 15, 20 people, then you find a safe dose and you move ahead. But in these studies, they treated quite a few patients, and these patients were very sick too. They had either one chemotherapy or even two chemotherapies before they went into these studies. Now, those who had two chemotherapies, in all honesty, there was really nothing else that had a chance to help them in terms of a different chemotherapy. But here is the survival curve from these patients. Again, it was not a huge number, about 129 patients who got treated with this drug after failing frontline or even second-line chemotherapy, and the 5-year survival rate is 16%. Now people say, well, gee, that doesn't sound so good. But here's to put it in perspective. If these patients got a third or a second type of chemotherapy, the number who would have survived at 5 years, I believe, would have been down here, 0 to 1%. And other studies, I'm not showing all the different ones. So one of the studies showed that the 5-year survival rate in a similar group of patients is almost 25%. So this is amazing. Now, the next thing that happened is immunotherapy, pembrolizumab, you see it advertised on TV as Keytruda, was compared to chemotherapy as the first treatment in patients who had a high level of PD-L1 in their tumor. And here's the slide showing the disease control rate, immunotherapy up here on the purple curve, blue chemotherapy down here. So immunotherapy way, way better. And Here's the survival. Again, this is a short-term follow-up. In the next year or so, we'll be seeing a long-term follow-up. But again, immunotherapy is significantly better than chemo in this group. Those tumors had high amount of the protein PD-L1 that I talked about in that slide before. That's a protein, if it locks horns with the protein on the lymphocyte, it shuts it down and the lymphocyte can't kill it. You take this antibody, you block it, now the lymphocyte can kill it, and it helps people to live longer. Now here's a double antibody study, two different immune checkpoint areas where these agents work. They're both antibodies. And in this study, again, what we're seeing is the green curve, keep immunotherapy versus chemotherapy significantly better. And in this study, it was not just PD-L1 very high, like it was in the Keytruda study. It was just any little level of PD-L1 was allowed. And that's roughly 2/3 of lung cancer patients will have just a little bit of PD-L1 or higher amounts. Again, significantly better survival with immunotherapy versus chemo. These are practice-changing studies. Well, so it looks like maybe chemo's going away, but maybe not yet. Here's pembrolizumab chemotherapy, or pembrolizumab, also called Keytruda, combined with chemotherapy versus chemotherapy alone as the first line of therapy in patients with stage 4 lung cancer. And here again, the chemo and Keytruda way better than the chemo and placebo. So a very big difference. Again, another practice-changing study. Stage 3 lung cancer, which is cancer which is limited to the chest, but generally beyond the chance of removing it with surgery, we had discovered, and actually Rush was involved in the very first studies, showing that chemo and chest radiation could be given concurrently safely. Then subsequently bigger studies were done, and it showed that chemotherapy and radiation were better than radiation alone. Some of these patients also get chemotherapy and radiation followed by surgery. And that, again, there's some controversy about that, but there certainly were good results with it in the hands of some investigators. So here we see a study where patients had stage 3 lung cancer. They all got treated with chemotherapy and radiation. And when that was completed, if their cancer was controlled, they got treated with a immunotherapy called durvalumab, or Imfinzi is the other name. And here we see, here's the people who got Imfinzi, here's the people who got placebo after the chemo radiation were done. A very big difference. We now have 4-year survival rate. This difference is being continued to see it, and we believe it's going to continue at 5 years and 10 years and beyond. So here are predictions. As Dr. Karush has shown, screening is gaining momentum. I believe it's going to gain more and more traction, and I think it's going to lead to a very significant decrease in lung cancer mortality because patients will come with early stage disease. Those who are surgical candidates will have resection with minimally invasive surgery. Those who don't have that will be treated, who can't go to surgery, will be treated with focused radiation, stereotactic body radiation therapy. We're going to see much higher survival rates in lung cancer. The targeted therapies and immunotherapies that we saw in the late stage patients are going to start to become important in early treatment of early stage patients. And we have at Rush have participated in 3 studies using immunotherapy after surgical resection of early stage patients. One study used an EGFR inhibitor, Tagrisso, that we talked about earlier. That study was recently published in the New England Journal and showed a dramatic reduction in recurrence rate, and we believe it'll also cause a dramatic reduction in deaths from lung cancer in patients whose tumors have the EGFR mutation. So targeted therapies will have some role. Immunotherapy will have a bigger role because there's a larger group of patients who are eligible for this treatment. There are not as many patients with those driver mutations. And precision medicine, I mentioned earlier, every adenocarcinoma patient should have molecular profile, genomic analysis, and also analysis of PD-L1. And in late stage disease, what our goal is, and we're seeing it more and more, we're converting this to a controllable chronic disease that people can live with. yes, they're on treatment. In fact, with immunotherapy, they're not on treatment. It stops after, it can stop at 2 years. Those patients are staying in remission. And that's why we believe, coupled with that slide where I showed the 5-year survival rates, of immunotherapy, many of us believe it's going to cure some of the late stage patients. And the other last thing I want to say is the progress that's been made in lung cancer within the last 10 to 15 years is almost exponential. I have to say, the first 30 or 35 years of treating people with systemic therapy, I didn't think I would see that before my career ended, but thank goodness I'm seeing it. And patients are living longer, and they're feeling better. And this is a wonderful thing. Thanks very much. Thanks, Michelle.